Lymphoma 101, a blueprint for understanding and navigating your subtype with confidence. We chose this topic because understanding your lymphoma diagnosis is an important step in taking control of your care. We are very excited to have Dr. Rhodes share her expertise on this topic with us today. Dr. Joanna Rhodes is the director of the Lymphoma program at Rutgers Cancer Institute, systems lead for lymphoma for RWJ Barnabas, and an assistant professor at the Rutgers, New Jersey Medical School. Her clinical interests are in chronic lymphocytic leukemia and lymphoma. Her research interests include the novel development of therapies for CLL and lymphoma. And with that, I will turn it over to Dr. Rhodes for her presentation.
Hi, everyone. Thanks so much. I'm just getting my slides up. Let me know. Are we good to go, Hannah?
Yep, that's perfect.
Awesome. All right. Well, thank you, everyone, for joining us during this beautiful afternoon, at least beautiful in New Jersey, and for taking the time to listen to this talk. As Hannah said, I'm Dr. Joanna Rhodes. I run the lymphoma program right now at the Rutgers Cancer Institute. And I agree with HealthTree. I think that sort of understanding what is lymphoma, what your lymphoma diagnosis is, and then understanding what our treatment goals are is of the utmost importance in your lymphoma care and in building a relationship with your doctor and your medical team. So this is a brief overview of what we are going to cover. I think one of the things that we often forget to talk about when we talk about lymphomas is, well, what is the lymphatic system and what does it do and why is that important? We'll then touch upon what is lymphoma and how common it is. And then I'm going to do a lot of talking about general things that should be going on during your lymphoma workup and diagnosis. And then we'll talk about very broadly the many different subtypes. There are about 80 different subtypes of lymphoma, and in a 40-ish minute talk, I can't talk about every single one in depth, but I am going to talk about a little bit more in depth on the three most common: diffuse large B-cell lymphomas and large B-cell lymphomas, follicular lymphoma, and chronic lymphocytic leukemia, small lymphocytic lymphoma, which I believe is I put into the category of lymphomas as well. And we'll talk a little bit about treatment options. And then I'm going to give a couple of my key takeaways for things that you should know and have in your arsenal as a patient. And then we'll have some time at the end for questions. I know that there are probably some of you on this webinar may have diagnoses that I won't have talked about specifically. So please feel free to ask questions as it pertains to those diagnoses. And I will do my best to give general answers. I, of course, cannot give any personal medical advice during this. Well, so let's talk a little bit to dive right in. So what is the lymphatic system? So our lymphatic system is made up all across our body. And I think that that's an important thing to remember when we think about how we potentially treat lymphomas, is that the lymphatic system is super duper important in what we do in maintaining our fluid levels and fluid balances. The lymph, which is the liquid that goes throughout this entire system, is actually part of our fat absorption system. And as we know, fats are an important portion, not just of our diet, but of our building blocks for cells in particular. And then our lymphatic system is super important, is the way that we fight infections. And so really, when we look at some of the glands and areas here on the right, these are areas that are really important when we think about things that perhaps get swollen when we have infections, and then also things that potentially can get swollen with lymphomas. And these are areas that we really do look at specifically when we're looking at a diagnosis of lymphoma. Tonsils, the thymus gland is actually where T cells learn how to be T cells, which is one of our immune system cells, learn how to be T cells. Our lymph nodes are actually where our B lymphocytes learn how to become B lymphocytes. So again, really important in our immune system. Our spleen is important in monitoring our blood homeostasis, so the levels of old blood cells, new blood cells. And then our bone marrow is our white blood cell making factory, or our blood cell making factory. And so this is where white blood cells, red blood cells, and platelets are created from and then go out into our circulatory system. So the immune system in and of itself is very large all throughout our body and plays an integral role of our day-to-day lives. Well, so what is lymphoma? So like I just said, we do have a lot of lymphoid tissue in our body, and many of our lymph nodes are also normal. You know, we do see, and I think the example I like to give in my clinic is, I think I remember my mom used to always ask me, are your glands swollen? Are your glands swollen? It's sort of one of these questions of how sick are you? And that's because we have lymph nodes within our neck that often can get swollen in the setting of upper respiratory tract infections. Lymphoma is a cancer of white blood cells and of the lymphoid tissues. And so when we talk about lymphomas, one of the things we often talk about is whether or not something is nodal or within our lymph nodes. So those lymph nodes that we have all throughout our body, or whether something is extranodal, meaning it's growing outside of a lymph node. And that can be different things. That can be our bone marrow is considered extranodal. Sometimes our organs are. Sometimes people can develop lymphomas in the skin. And so that's one of those key factors that we think about, not just when we think about lymphomas. And it might be a term that you come across, or it might even be a term that's part of your lymphoma diagnosis. So as I said, our bone marrow is where all of our blood cells are made. And so as we see here on the right, we sort of have these blood stem cells that turn into different types of white blood cells. And so we can have white blood cell, we have lots of different white blood cells that do different jobs. And I always say that the immune system, which is all of our white blood cells together, are really kind of like the Department of Defense. They're supposed to protect us both from sort of things on the outside, like viruses, bacteria, and fungus, as well as things from the inside. Well, our lymphatic system, our white blood cells are actually really important in catching abnormalities in our normal cells and getting rid of them before they potentially can cause cancer. And so again, we see here on the right, we have our blood stem cell. We get these sort of precursor cells, and as we go down, we get different types of lymphocytes. The three that we'll sort of focus on today are our B lymphocytes, whose ultimate job is to make antibodies to protect us infections. I think we think about that a lot when we think about vaccines and how they work. I know MMR vaccines are being talked a lot about, and checking your titers. So our B lymphocytes are really important for making those antibodies. We have our T lymphocytes, and our T lymphocytes are sort of like the generals of our immune system. And I think we often talk about T lymphocytes or T cells in the setting of HIV or AIDS, may have been one way that you have heard about them. These are the cells that get infected with HIV, and the lack of having them around is what makes AIDS happen, or what creates the diagnosis. And when we don't have our T cells around, we're very susceptible to rare infections, rare cancers. And so really having T cells that are functioning is really super important to protect us from infections. And then, while we won't talk about this, the plasma cell is also important, and that's the cell that actually makes antibodies and can potentially become a different type of blood cancer, something called multiple myeloma. So one of the questions that always comes up is, well, who is at risk for developing lymphomas? So oftentimes this is associated with older age, although there are some lymphomas that are more common in pediatric and adolescent young adult patients. Male sex is often associated with lymphomas, and non-Hodgkin's lymphomas are more common in white patients than in African Americans and Asian Americans. Radiation exposure can predispose to lymphomas, as well as certain chemicals and drugs such as benzene. And then certain medications can sometimes predispose to lymphomas. So sometimes some of the medications that patients can get for autoimmune conditions can predispose to potentially get lymphomas. Autoimmune diseases in and of themselves are associated with lymphomas, though there's never been a causative reason for that, but probably there's some immune dysregulation that allows for both of these processes to occur. And then sometimes bacteria and viruses can be associated with lymphomas. So we know that there are certain lymphomas that are associated with Helicobacter pylori, which is associated with ulcers. There are some that are associated with hepatitis C. We know that patients with HIV are potentially more prone to develop lymphomas and need to be treated differently. So I think that these are all some great things to know about the risk for developing lymphomas. And you may develop a lymphoma and have none of these risk factors. And so that just sort of speaks to the fact that it's probably a little bit more complicated than just these factors. All right, so what are the symptoms of lymphoma? So some people have some of these, some people have none of these when we find these, but often common symptoms include fevers, night sweats, weight loss, and then you may actually even feel your swollen nodes, which may have actually prompted you to go in to have an evaluation. Or sometimes swollen lymph nodes are found on other imaging that's done for other issues that come up. Sometimes on mammograms, sometimes if you have a CAT scan done of your belly for abdominal pain, things like that. Other things that I often find that can be associated, it's fatigue. So a lot of patients notice that they've had, leading up to a lymphoma diagnosis, an increasing amount of fatigue going on. Some people can have rash. In particular, for patients that have lymphomas involving the skin or may have little subcutaneous nodules. And with rash, some people can have a lot of itching, or you can have itching potentially without any rash itself. Some people may have shortness of breath or chest pain, depending on where their lymphoma is developing. And similarly, some people can notice swelling of the limbs, depending on where their lymphoma is developing. Because, like we showed, we have lymph nodes all throughout our body. So sometimes, if they compress upon some of the blood vessels that are important for draining fluid, we can start to see some swelling in that area. So what is the general approach to a lymphoma patient? So I think the way that I look at this is, I think of this in sort of three different spots. We have, well, what is the diagnosis? And I often in my clinic will call this the fact-finding portion. So there are a lot of things that go into making a lymphoma diagnosis, and really understanding what that diagnosis is, really, I think is very important for all the rest of your treatment going down the line. Next up is staging. So we need to know where the disease is when we start, in particular if we're doing treatment right away, because I would want to know, is my treatment working? And if not, what do I need to change to? So staging is important. Staging in lymphoma is different than I would say it is in other types of cancers. And we'll talk about that a little bit more, because I think there's differences in treatment, but also there's differences in long-term outcomes in comparison to solid tumor cancers, like things like breast cancer and colon cancer, which I think is also one of the things that I often will go through with patients in my clinic. And then the other thing is the treatment goal. So there are so many different types of lymphoma, and our goals of treatment are different for different lymphomas and different for different patients, depending upon where you are in your lymphoma journey, and as well as what are the other things going on maybe in your life from a social perspective. What are some of the things going on in your life, maybe from a health perspective, that may impact the treatment of your lymphoma. So this is, I think, very tailored to patients specifically at the time of diagnosis, once we've confirmed a diagnosis and a stage. So ultimately, how is lymphoma diagnosed? So we always need tissue in order to be able to diagnose lymphoma. Now that tissue may be from a lymph node. It may be from the bone, something from bone marrow biopsy. Sometimes for certain patients, we may be able to get the diagnosis just off of a blood test. So it's going to really depend on your clinical situation and what's going on. These are the three types of biopsies that we often will do for patients with lymphomas. So a fine needle aspiration can be done, but really doesn't usually give enough tissue to be able to distinguish between the 80 different subtypes of lymphoma. And so if something's found that's abnormal on an FNA, it may mean that you need to undergo another biopsy in order to really drill down on the diagnosis. And as I said before, and really the premise of this talk is understanding your diagnosis, and your doctor also wants to understand your diagnosis to the best of their ability to, in order to be able to help determine what best treatment is. The next sort of less invasive biopsy, but with a bigger needle, is something called a core needle biopsy. Again, this is done outpatient and can be done in varying places, such as the stomach, the areas near the spinal cord. But sometimes, again, a core needle biopsy, because it's just a needle, may not yield enough tissue for someone to look at it underneath the microscope to be able to distinguish between the different subtypes of lymphoma. And it may be that we need to get more tissue in order to really establish what the diagnosis is. And then finally, the last biopsy we have is a surgical biopsy. So we call that an incisional or an excisional biopsy. This really is our gold standard for biopsies. Previously, and many years ago, we didn't actually have the ability to do the fine needle aspirations and the core needle biopsies the way that we do now. And so most patients did get surgical biopsies of enlarged lymph nodes. And this really gives us usually enough tissue to be able to confirm a diagnosis, with pretty good certainty that that's what is going on. The challenge with that is that it is more invasive. I can't set this up in my office. You need to meet a surgeon potentially, whether it's a ear, nose, and throat doctor or a surgical oncologist or a general surgeon to be able to do this. So sometimes it can take a little bit more time to set up and does require potentially going to an outpatient surgical center, or depending on the type of biopsy, could even involve a hospital stay. So what other tests are often performed when a diagnosis of lymphoma someone has a suspicion of a diagnosis of lymphoma or as part of the regular workup? So scans are often how we initially find lymphoma, whether it's a CAT scan, and then often we'll do something called a PET scan as well as part of the initial workup and staging. What a PET scan is, it's a CAT scan, but we also give you a radionucleotide that's tagged to sugar, to glucose. What that does is it goes to areas where there's increased cell turnover, and all over our body, our cells are using energy all the time. But there are some places that use less and some places that use more. And really what we find is that places that have lymphoma often will be having increased cell turnover, using more of your cellular energy, and will often light up on a PET scan and allow us to really help with staging. And then sometimes even we use PET scans to help us figure out how to plan a biopsy. Sometimes, depending on the type of lymphoma, your provider may recommend doing an MRI of your brain, because some lymphomas can go into the spinal fluid and into the brain. And so sometimes we need to look for that as well at the time of diagnosis or even later on. Sometimes we do bone marrow biopsies. It's not for every patient. I don't do as many bone marrow biopsies as I used to, because we have different tests now that potentially haven't replaced but are useful as well. But a bone marrow biopsy may be something that gets done if there are any abnormal blood counts or if it's part of its staging system. There's a bunch of different sort of specialized blood tests that we often can do, and that's really going to be tailored to the type of lymphoma that you have. And it's a good question to ask your physician, are there any special tests that need to be done to understand anything else about how my lymphoma may behave in the future? Sometimes we'll do a spinal tap. What that is we go into the spinal fluid and take a sample. We'll often give chemotherapy when we do that. And that's, again, for some of these lymphomas that have a tendency to potentially go into the spinal fluid in the brain, because that is important information for us to have in order to make a treatment plan. For patients that are of the age of being younger and potentially being in childbearing years, we talk about fertility preservation, and that's really for patients that are getting chemoimmunotherapy. Again, that's also going to depend on the type of treatment, the type of lymphoma, but if that would potentially pertain to you, you're in the process of planning a family, you want a family in the future, is again something to bring up to a provider. Many of our chemotherapies can affect other organ function, in particular the heart and the lungs. And so sometimes we'll do things like echocardiograms, which is an ultrasound of the heart, to look to make sure the heart pump function is normal, as well as pulmonary function tests to make sure that there's no differences in how your lungs are functioning before we start treatment. Okay, so we talked a little bit about the overarching plan, how some of the tests that are done. But now the next question is, well, how is lymphoma staged? So we have a staging system. It's actually called the Ann Arbor staging system, in case you read that. And it's used for the majority of our lymphomas, with the exception of CLL. So what does staging mean? Well, staging really just means, well, where is the lymphoma located at the start of treatment? And we can see in this lovely diagram on the right, we have stage 1 lymphoma. Stage 1 lymphoma is all in one area, and it's actually one area that encompasses what we would consider a radiation field. Radiation is a potential modality of treatment for lymphomas that can be used, but is not always used. We have stage 2, meaning it's in multiple different places, but it's either all above the diaphragm or all below your diaphragm. So either all chest and above or all stomach and below. We have stage 3, which means means that you might have lymph nodes above or below the diaphragm, and also the spleen could be potentially enlarged or involved. That is the spleen, like we showed initially, is a lymphoid organ, so it definitely can be involved with lymphomas. And then stage 4 is when we see lymphoma outside of the lymph nodes in the spleen. So could it be in the bone marrow, like it's shown here with this femur bone? Could it potentially be in the liver, which can happen too? Really, it just means that there's lymphoma outside of a lymph node. Now, an important thing to note is that stage 4 lymphoma is not the same as a stage 4 breast cancer or colon cancer. And I think that this is one of a key takeaway that I always like to talk to patients about. Yes, it means your lymphoma is in more places, but it doesn't necessarily mean that there's a change in treatment or that there's a change in the treatment goal, which sometimes can be, you know, prolonging the time till your next treatment, depending on the type of lymphoma, or potentially looking for, a cure with one type of treatment once and having the lymphoma never come back. And then one of the things that's also part of our staging system is looking at whether or not you're having symptoms related to your lymphoma. So like on that first picture, whether you're having fevers, night sweats, you're losing weight unintentionally. And then we look at whether or not your spleen is involved. Are there any lymph nodes that are very large, which we call bulky? And then whether or not there's any disease outside of the lymph nodes. Okay, so how common is lymphoma? So in 2024, it was expected there would be about 110,000 new cases of lymphoma in the United States in the year. Most of those would be non-Hodgkin's lymphoma, and about 10% of them would be Hodgkin's lymphoma. So that's showing sort of that first branch point of how we think about categorizing lymphomas. So this isn't so when we look at it in comparison to other types of cancers, it's not the most common, but it is one that is very prevalent. So let's talk a little bit about what are our different lymphomas. So the way that I first like to think about this, and the first sort of branch point, is whether something is a Hodgkin's lymphoma or a non-Hodgkin's lymphoma. Hodgkin's lymphoma is its own specific entity, and it's an important and making that distinction between a Hodgkin's lymphoma and a non-Hodgkin's lymphoma is super important because the treatments are different. Today, we're going to focus on the non-Hodgkin's lymphomas, and that's because there's more differences between the subtypes, and so understanding sort of the differences between these diseases, I think, is super important for patients. So this is looking at the relative frequencies of our B-cell lymphomas, and that's going to be the focus on what we talk about later on for treatment, although we're going to talk a little bit about T-cell lymphomas in the next slide too. So what are some of our common B-cell lymphomas? Well, the most common we see here in the green is diffuse large B-cell lymphoma. That makes up about 30% of our cases of B-cell non-Hodgkin's lymphoma. And then the next most frequent is actually chronic lymphocytic leukemia and small lymphocytic lymphoma, about 25%, and then about 15% of patients with follicular lymphoma. Now, other B-cell lymphomas that are perhaps more rare but are still common and are notable to talk about, because I think that they're diagnoses that I see very frequently in my clinic, includes the different marginal zone lymphomas. So there are a bunch of different subtypes. We have splenic marginal zone lymphoma, which is this one in the light purple. We have extranodal marginal zone lymphoma. So again, talking about that extranodal might be part of your diagnosis, here at about 5%, and then nodal marginal zone lymphoma at 3%. So about 10% of our B-cell non-Hodgkin's lymphomas are marginal zone lymphomas. Hairy cell leukemia, even though it's called a leukemia, is a B-cell disease, and so we put it into the basket of these B-cell non-Hodgkin's lymphoma. And then we have more aggressive lymphomas, things like Burkitt's lymphoma, and then also we have mantle cell lymphoma as well, which makes up about 4%, and then Waldenstrom's macroglobulinemia or lymphoplasmacytic lymphoma, which makes up about 3%. Now, that's obviously a lot, and there's even further subtypes beyond this, but we won't talk about that just yet. Now, T-cell lymphomas, there are also many different subtypes, although we often lump T-cell lymphomas all in together. But I think that that's really challenging, especially as a patient, because there may be treatments that are specific for your subtype of T-cell lymphoma that may not get discussed. And again, at the end, I encourage, if anybody has questions about T-cell lymphoma, please bring them to us, because this is an area that often because it happens less frequently, we talk about less in these types of forums. But really the most common subtype of T-cell lymphoma is something called peripheral T-cell lymphoma, not otherwise specified, which is basically a basket of, it's not these other things, but it is definitely a T-cell lymphoma. We also have something called mycosis fungoides, and so that's T-cell lymphoma of the skin. And that actually can potentially turn into T-cell lymphoma that goes into the lymph nodes or into the bloodstream, which is something called Sézary syndrome. Again, this is there are very specific treatments for this as well, and very specific staging systems for mycosis fungoides as well. And then as you can see, we really have small, outside of having this 13% that's for ATLL, which is a very specific virally associated T-cell lymphoma. We are seeing that T-cell lymphomas, the different subtypes, are reasonably rare. And so I think that that's one of the challenges with T-cell lymphoma, and why I always recommend it's a good idea to consult with a T-cell lymphoma expert at the beginning of your diagnosis to ensure that the diagnosis is correct, as well as coming up with a longitudinal treatment plan. Okay, so we talked a little bit about this. So we categorize lymphomas in terms of Hodgkin's lymphomas, B-cell non-Hodgkin's lymphomas, and then T-cell non-Hodgkin's lymphomas. So this is basically all of this just all in one spot. And then within the B-cell non-Hodgkin's lymphoma, I like to put because there are so many different subtypes and they all do have different treatments and they all have different treatment goals, I kind of like to lump them into baskets about how the lymphomas themselves behave, because I do think it gives us an idea of how they're going to be treated, as well as sort of what the treatment goals are. So we have our more indolent or slow-growing lymphomas, which include follicular lymphoma, CLL, marginal zone lymphoma, and lymphoplasmacytic lymphoma or Waldenstrom's macroglobulinemia. We have our aggressive lymphomas, which include diffuse large B-cell lymphoma. Mantle cell lymphoma can be aggressive or it can be indolent. So I think that that's one that sort of spans the between the two boxes and really depends on some more information. And then we have our aggressive lymphomas. So our Burkitt's lymphomas are very aggressive, and often if I meet a patient in the office, I will be sending them to the hospital because those lymphomas can progress very quickly and can make people very sick. Okay, so we're gonna move over, we're gonna talk a little bit about the behavior of aggressive lymphomas. So I think one of the other questions that often comes up is, well, is this a good lymphoma to have? And I don't love to say that something is good or bad, because that really just depends. What really matters is how you do as a patient with your lymphoma diagnosis, how you manage and treatment, and how that fits into your life. So really, what are some of the things that are important about aggressive lymphomas? Well, they are considered curable. And so that is the goal of our upfront therapy, and even our subsequent lines of therapy, is to get rid of this lymphoma and have it never come back. And we have very effective therapies as well. And the type of therapy will depend on the type of lymphoma. But I think that that's an important thing to remember. Often this means it's IV therapy. Usually it's often chemotherapy based. And so I do think that that's an important thing to remember if you have a diagnosis of aggressive lymphoma, is that there's probably going to be treatment. It's probably going to start soon, and it probably will need to start relatively quickly, as well as the treatment is likely to have an IV component. The challenge is that while we cure many patients, we don't cure everyone. And so sometimes you need subsequent lines of treatments, and that can require multiple treatments in a row. And what those are will depend on your lymphoma subtype as well. Aggressive lymphomas often present with symptoms, and so that can be very challenging to start off feeling not great. And then I'm going to tell you that you need chemotherapy, and that can be very challenging, although often symptoms will improve as we start treatment. The other challenge with not curing aggressive lymphomas with the frontline is that there are patients that get multiple lines of treatment that we may not cure, and that's of course very challenging. For most of the patients with aggressive lymphomas, just monitoring is not an appropriate treatment, because we know at some point that lymphoma is likely to make you symptomatic, and the goal of treating an aggressive lymphoma is cure. So we like to start treatment quickly. So like I said, there are lots of different subtypes of large B-cell lymphomas, which are considered aggressive B-cell lymphomas. This is just a few of them. And the reason I put this in there is to kind of show you that although I've put these lymphomas into baskets, there are a lot of different things that we think about when we think about treating a large B-cell lymphoma. And I'm going to show some potential treatment options, and what the type of lymphoma is going to potentially impact the type of treatment that's offered. And so what is offered to one person with diffuse large B-cell lymphoma may be different than what someone is offered who maybe has a primary mediastinal B-cell lymphoma or something a little bit different. So I think that that's an important thing to think about and to remember, is that really we're tailoring treatment towards your type of lymphoma, your stage, your diagnosis, and your treatment goals. So what is diffuse large B-cell lymphoma? As we said, it is the most common type of non-Hodgkin's lymphoma. It starts in our B cells, which we said is a white blood cell that normally helps the body fight infections. These are aggressive lymphomas, meaning that if we don't start treatment, the likelihood is over time you will potentially develop symptoms and issues related to the lymphoma, but it is treatable and potentially curable. Like we talked about before, some of the symptoms include swelling of the lymph nodes, fevers and night sweats, unexplained weight loss, and people can feel very fatigued. And again, it can occur in not just in lymph nodes, but can outside the lymph nodes, like the stomach, the intestines. Sometimes it can even be in the brain or only in the brain. One of the things that as you go on your lymphoma journey, if you have diffuse large B-cell lymphoma, and you may read about, is that there are some ways that we risk stratify patients based on something called the International Prognostic Index. And that can just be important for determining what treatments you may need. So what are the potential treatments for large cell lymphoma? So in the frontline setting, we are looking at chemoimmunotherapy treatments. And really the gold standard for many years was this thing R-CHOP, which is these drugs: rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone. While we cure many patients with R-CHOP, we're always looking to cure. The goal is really to cure 100% of patients the first time around. And so we've done lots of different things to potentially try and improve upon the R-CHOP backbone. Most recently, the newest frontline treatment option on the block is something called Pola-R-CHP, where basically we take polatuzumab vedotin and we replace vincristine. Subsequently, we also have dose-adjusted R-EPOCH, was another way of intensifying chemotherapy, and it's dose-adjusted to target different white blood cell counts. I call it kind of Goldilocks chemo. We want to give you the most amount of chemo that we can, but we want to do it in the safest way possible to prevent any side effects. Now, so like I said, we potentially cure many patients with frontline treatment, but what are the options for relapse refractory large cell lymphoma? So here again, we're looking potentially at various kinds of chemoimmunotherapy. There are lots of different drugs out there right now, and different ones are approved in different lines of therapies. And it may also be that a clinical trial could be recommended in this scenario. The other thing that's important, and we'll go into just a little bit, is immunotherapy. I'm sure many people have heard about chimeric antigen receptor or CAR T-cell therapy, which has sort of revolutionized, I would say, how we are trying to cure patients with relapsed and refractory diffuse large B-cell lymphoma and other types of relapsed B-cell lymphomas. And then now we have a new thing called bispecific antibody therapy, which basically binds to your T cells, so binds to those generals of your immune system, binds to your lymphoma cells, and then reminds the general that there's something there that's not supposed to be there and activates your immune system to get rid of them. For certain patients, autologous stem cell transplants are also a potential option, although the number of patients that are getting autologous stem cell transplants are a little bit smaller than it was about 10 years ago because of some of the newer agents that we're using. And just because this has become such an important part of our lymphoma armamentarium, I just wanted to show what a chimeric antigen receptor or CAR T cell is. What we do is we basically take your T cell and we engineer it with this chimeric antigen receptor that binds to a target on your lymphoma cells and basically teaches it how to fight your lymphoma. So patients will get get their T cells removed from their body. We manufacture them to be able to do this, to be able to recognize specifically something on the lymphoma cells, and then we get them back and then we will give them. And the ultimate thing that happens is that we have this CAR T cell that can target your cancer cell based off of this target marker on the cell surface, something called an antigen, and leads to cancer cell death. Okay. So we only have a few minutes left, so I'm going to go very quickly through two of our indolent lymphomas. So our indolent lymphomas are all of these here, and these all share some similarities in that the lymphoma pathogenesis, while it's very different between all of these, there's some similarities, and because of that, there can be some similarities in treatment. And so I think that that's important to remember, especially if, let's say, you have a lymphoma diagnosis that is looks a little bit like one thing, but also looks a little bit like another, which often can happen with some of our lymphomas, like marginal zone lymphomas and Waldenstrom's lymphomas. So something to just remember that a lot of these have a lot of overlap in treatment. So what is the clinical behavior of our indolent lymphomas? Well, these are typically not aggressive. So when we find them, we may not actually even need to start treatment right away, which I know can be very challenging because the whole idea of sort of surveillance for other types of cancers is the earlier you find it, the more likely it is to be cured. That's not necessarily the case with indolent lymphomas because often they're very slow growing and you may not have any symptoms related to it for many years. And with that, we talked sort of a little bit about prognosis. So there are some patients who are diagnosed with an indolent lymphoma, and they may, right at the start, already probably be probably are likely to live their normal lifespan, which I think is something that's important to remember when we think about a lymphoma that may not need treatment, but again, might still go on to live the normal lifespan. We have a lot of different treatments for these lymphomas. So even though one of the major challenges that these aren't curable, meaning that I can't do treatment once and expect them never to come back, I have a lot of things that we can treat with, many of which that are not chemotherapy, that are sort of targeted agents that are, that block some of the ways that these lymphoma cells replicate and stay alive. And so that might be that may be something that a patient with indolent lymphomas may get. I think one of the other challenges that treatment, while it may feel less intensive, it often can be longer or even indefinite. And sort of treatments often can go until the lymphoma comes back or you develop a symptom or a side effect related to the medication. And so that can be challenging as well because this really becomes more of a chronic disease and something you're dealing with for a short period of time. And again, you may need multiple treatments over time. And so that's challenging that this is something that, may go away for a while, may come back, and may intermittently require treatment. One of our most common subtypes of indolent lymphomas is follicular lymphoma. We have different grades of lymphoma, and that basically just looks at how things look at underneath the microscope. And it's important for us to have that tissue to be able to do that because we want to make sure we're treating the follicular lymphoma very appropriately. And grades 1 through 3A are actually treated all the same. But 3B, we treat more like an aggressive lymphoma, more like diffuse large B-cell lymphoma. So making sure that we know that differentiation point, I think, is very important. And again, just like in diffuse large B-cell lymphoma, we have an international prognostic index that kind of helps us sort of tailor treatment and when we potentially start treatment and what treatment will look like down the line. Well, what are our potential treatment options? For some patients, we may just use radiation if it's in one sort of field, if it's a stage 1 follicular lymphoma. For other patients, we may use chemoimmunotherapy, and these are some of the most common regimens that we use. We often will use bendamustine with rituximab. You'll see sometimes using similar regimens that we use for diffuse large B-cell lymphoma, like R-CHOP. And then we also have what we consider a chemotherapy-free approach, which is rituximab with a drug called lenalidomide or Revlimid, which is why we call it R-squared. And that also can sometimes be used for patients in the frontline setting. For patients with follicular lymphoma and other indolent lymphomas, sometimes we do maintenance therapy, which we often don't do for aggressive lymphomas, meaning that we keep you on a little bit of treatment long-term to sort of push off the time potentially that lymphoma could come back. And we have lots of treatments for relapsed follicular lymphoma. Again, somewhat similar to some of the treatments that we have in the frontline setting, including monoclonal antibodies like rituximab, the immunomodulatory agents like lenalidomide, and then we have the bispecific antibodies now. We also have other targeted agents, such as tazemetostat or zanubrutinib, which are often used. Zanubrutinib is used in a lot of different B-cell lymphomas. So again, like I said, there are some similarities in how we treat things. And then also we can use chimeric antigen receptor T-cell therapies in later lines of therapy for follicular lymphoma. So these are all some things that may actually come up for you as well. All right, and finally, in the last 2 minutes, I'm going to talk very quickly about CLL. So CLL is a diagnosis where we often will see an elevated lymphocyte count in the bloodstream, and then also sometimes we'll see enlarged lymph nodes as well. Sometimes we'll pick up a small amount of abnormal lymphocytes in the bloodstream that don't make the diagnosis of CLL, and you can have something called monoclonal B lymphocytosis, which can be a precursor to CLL, although not all patients go on to develop CLL that have MBL. There's specific testing that's performed for patients with CLL. We do FISH testing to look for certain genomic markers and some mutational analysis as well. And really, I think one of the things to figure out is when we're going to start treatment for a CLL patient. So sometimes so often it will have to do with these symptoms such as fatigue, night sweats, weight loss. Really anything that I find affects patients' quality of life now that our treatments are so safe can be used. Oftentimes it's low blood counts, including a lowering of your platelets, anemia, and other autoimmune complications. And sometimes it can be the amount of lymph node disease that you have, whether or not your spleen is enlarged, and how quickly it does appear that the CLL is progressing based off of the white blood cell count, although there's no magic white blood cell count that tells us that we must start treatment. And I think that that's really important for a CLL patient to know, is that there is no magic number that we say, once you get to this number, we start treatment. Potential frontline options for CLL therapy. So really, we've moved away from chemoimmunotherapy for patients with CLL. I do not give bendamustine in my own clinic, and I don't think that there are any patients in the United States that should really be getting bendamustine for CLL, so that's something important to remember. And really, we're looking at targeted agents, things like BTK inhibitors in combinations with monoclonal antibodies. Sometimes they're given continuously, or sometimes we can even do treatment for a fixed period of time with BTK inhibitors, a drug called venetoclax, which is a BCL2 inhibitor, and obinutuzumab as well. And then really the treatment options for relapse CLL depend on what you've gotten before, what the response was to the prior treatment, and the reason that you're stopping treatment. Was it for a side effect? Is your CLL progressing on the treatment? And again, really the same drugs can potentially be used, including the addition of a new drug called pirtobrutinib, which is a non-covalent BTK inhibitor, and CAR T cells, specifically lisocabtagene maraleucel, are actually approved now for CLL as well. So I think that these are the sort of key takeaways that I wanted to talk about in terms of treatment, because I think that they're super important. So just knowing what your treatment options for your lymphoma are and why, and then really understanding what your goal of treatment is. So is this an aggressive lymphoma where my goal is cure? Is this an indolent lymphoma where I'm really hoping to control symptoms and put off the time that the lymphoma becomes active again? I think importantly for some people, if there is an oral agent, is it an option? And what are the pros and cons of using that compared to IV drugs? Well, how are we going to look to see is treatment working? So what are we doing to make sure that I'm responding to treatment? I think most importantly, understanding the risks and the side effects, and then making sure that your physician and your care team are taking any side effects seriously and managing them aggressively is important. Quality of life to me is one of the most important things for patients, particularly for patients if you're going to be on longer term treatment. And so I think that that's really important. And then asking about what are the other things that you can do. Diet can be very important. I think exercise and moving is incredibly important, and kind of figuring out how that fits into your treatment schedule is important for you. Okay, so what are our key takeaways? So I think ensuring the correct diagnosis is key when you have a new diagnosis of lymphoma, because it really does tell us what we're going to do from a treatment standpoint. And then I know that this is a very frustrating thing because if we don't get the right answer the first time, we may need to do other biopsies. And being in limbo of not knowing what your diagnosis or treatment plan is very challenging. I would say that also we're in a time where there are very many effective therapies in lymphoma, and depending on and the therapies are going to depend on your lymphoma subtype, what's offered, and how effective those agents are will also be dependent on the lymphoma subtype as well. And again, your treatment is going to be tailored to your diagnosis as well as anything else that is going on with you personally, whether it's other medical conditions, age, things like that. And most importantly, I think developing a close working relationship with your doctor and your care team that could include, an advanced practice practitioner, a nurse, even the administrative, the scheduling office is so important in creating the therapeutic relationship. And I really think that that's key. And with that, thank you so much. And I will take questions. I'm so sorry I ran over.
That was a wonderful presentation. Thank you so much for that, Dr. Rhodes. So yes, now it's time for the discussion part of today's webinar. If you have any questions about the topic, feel free to drop them in the chat. And our first question is, do you have any recommendations for lifestyle habits during watch and wait for follicular lymphoma?
This one comes up a lot because I think that when you have a diagnosis that you're not necessarily going to start treatment, and one of the questions is, well, what I can do to prevent needing treatment? And we don't know if there's one thing specific that will do that. But one of the things that I often talk about is, well, what are the things that we can do that are good for health overall? So, doing some sort of exercise, 30 minutes a day, 3 to 4 times a week has been shown to decrease inflammation, improve cardiac function, which I think is important. I get asked a lot about diet. We don't have any data about diet specifically in lymphomas. There's some data coming out now from multiple myeloma that plant-based diets may be useful, but we don't know what it would mean in the sense of patients not on treatment. Would diet prevent progression of disease? But I do say that doing things that are heart healthy or Mediterranean style are probably going to be useful just in terms of overall physical condition and health benefits. And so that's usually where I steer patients to as well. And I think one of the most important things during active surveillance and watch and wait is ensuring that you have a care team that you feel is listening to some of your concerns. And then I think the other portion is there's a lot of psychological distress that can come with having a cancer diagnosis and not getting treatment. And so I do think that if there are any concerns, if you're developing any anxiety or depression around your diagnosis, this is a really good time to also find a team of mental health care providers that can help support you, because it's the complete opposite of what we talk about with so many other kinds of cancers. And so I do think that it's a really challenging thing to sort of stomach and to kind of come to terms with, that I have something, but we don't need to do treatment right now.
Thank you for that answer. And then our next question is, do you have any online resources that you would recommend looking at for someone who's newly diagnosed?
Oh, yes. So I think HealthTree has a lot of great resources. There are other organizations that do as well. Lymphoma Research Foundation, Leukemia Lymphoma Society, CLL Society, if that is, if you have CLL. Those are all places that have, just like HealthTree, that have information that's vetted by experts. And I think that that's the most important thing. One of the challenges if you type lymphoma into a computer is that there's a lot of information out there, and a lot of it, like I said, may not be related to you because there's so many different subtypes of lymphoma. So I think navigating the wealth of information that's out there is so challenging, but I think that that's why places like HealthTree are so wonderful and a great place to start to get some research done.
Thanks for that answer, and thank you for the shout out to HealthTree. Our next question is, can you talk a little bit more about using an MRI of the brain in the diagnosis of lymphoma?
Yeah. So an MRI of the brain isn't done in all cases. The times that I will do an MRI is for certain subtypes of lymphoma that have a tendency to potentially go to the brain. or if somebody is having neurologic symptoms at the time that they're coming to see me. There is a type of large cell lymphoma called primary CNS lymphoma or primary central nervous system lymphoma that is relatively rare, but it basically means you only have lymphoma in the brain or in the spinal fluid, and that's treated differently than a lymphoma that you have in the lymph nodes or other extranodal sites, extra sites outside of the lymph nodes. And additionally, if you're having neurologic symptoms at the time of your lymphoma diagnosis, that may be a useful tool as well. In particular, let's say for patients with diffuse large B-cell lymphoma. Sometimes we can, at diagnosis, also find lymphoma either in the spinal fluid or in the brain, and that does change what our treatment options are going to be.
Perfect, thank you. And then the next question is, can lymphomas change from one type to another, and does that happen a lot?
Great question. The most common time that this happens is with some of the indolent or more slow-growing lymphomas. They can turn into more aggressive lymphomas. It is a relatively rare thing to have happen. Depending on the subtype of lymphoma, it can happen anywhere from 1 to 5% of the time, depending on sort of what some of the clinical factors are. So, for example, follicular lymphoma can turn into a more aggressive lymphoma, like diffuse large B-cell lymphoma, and that really happens around 3% of the time. But so it's a rare occurrence, but can happen. The other lymphoma that often can sort of transform is CLL, can become a more aggressive lymphoma, and that can become either a diffuse large B-cell lymphoma or rarely a Hodgkin's lymphoma. And so that's also something to consider. But all of the indolent lymphomas have the potential to become more aggressive, including marginal zone lymphomas, and Waldenstrom's as well, though it's a relatively rare event for those.
Thank you. Our next question is it common to have a lot of PET scans? This patient has had 7 so far.
So there's no clear guidance as to imaging. Let me rephrase that. Imaging is a really challenging thing because oftentimes we'll be looking to see if lymphoma is coming back or if lymphoma is progressing. And a lot of it is dependent on what is going on symptoms wise with you. I have a tendency to do, for my indolent lymphoma patients, to do fewer scans after the first year or two, just because if patients are feeling exactly the same as when I met them, the likelihood that I'm going to start treatment is lower than if they've developed a new symptom and then I'm cured, and then I want to know, well, is that symptom related to progressive lymphoma? Within the aggressive lymphomas, there are guidelines for Hodgkin's and diffuse large B-cell lymphoma and other lymphomas where chemotherapy is used with a curative intent. And really, we don't recommend doing scans after the first 2 years because that's when most of the recurrences will occur. And there's a lot of debate even amongst experts about what's the number of scans that we should be doing. Should we be doing any scans at all, even in that scenario? So I do think that there's some, I don't know if there's such a thing as too many PET scans, but I think the question to ask your physician if you're worried about it is, what are we looking for on this scan at this point, and why do we need it?
Perfect, thank you. And then another question is, how is double hit lymphoma different from regular DLBCL?
Excellent question. So we know that, just like I had said, there's some genetic markers that can be looked at, and it's different for each lymphoma. In diffuse large B-cell lymphoma, we know that there are a couple of gene rearrangements that really do make a difference in terms of how well you may respond to upfront treatment with certain types of chemotherapy. And the reason that we like to know that is, one, this is again an area where there's a lot of debate. I will often treat patients that have what we call double hit lymphoma, which is being removed from the guidelines now, which means that you have a rearrangement of a gene called MYC and a rearrangement of a gene called either BCL2 or BCL6. Those are sort of but MYC is really the big one that's important there. It means that the lymphoma may behave more aggressively, including there's a higher risk potentially that it could get into the spinal fluid in the brain. And so your doctor may want to do things to prevent that from happening, and also may want to look at the beginning of treatment to make sure that that hasn't happened yet.
Thank you. And then the next question is, are T cell lymphomas treated differently than B cell lymphomas?
So the backbone of treatment for T cell lymphomas does depend on whether or not it is within the nodes or the skin only. Skin only T cell lymphomas are often treated with topical treatments. There's light treatments that we use and other oral or IV therapies that we can use to help with that. T cell lymphomas that are in the nodes are often treated with CHOP, so that's similar backbone, but without a drug called rituximab because T cells don't express the marker that the rituximab goes against. Some T cell lymphomas express something called CD30, and that's an important thing to actually ask your physician because we do have a drug, something called brentuximab vedotin, that does target that. And so for some patients, adding that in and removing the vincristine may be something that is appropriate for your case.
Thank you. And then I think the last question we'll have time for today is, are clinical trial options different depending on the type of lymphoma you have?
Yes, so there are different ways that we treat different lymphomas, and so the clinical trial options are different. Clinical trials are potentially an option, early on in treatment, whether it's your front line of treatment, whether or not you've had treatment before and need a new treatment. And it's also going to depend on the type of clinical trial, whether it's an early stage trial, like a phase 1 or 2 study, where phase one trials are looking, is it what's a safe dose of a drug to give? A phase 2 is looking, well, is that safe dose really effective? And then a phase 3 is looking at, well, is this new drug that we found a safe, effective dose for better than what we would do right now? And so that's, I think, there are different trials for different lymphomas, and they'll also be the drugs may potentially be at different stages of development. And the drugs for Hodgkin's lymphoma, B cell lymphomas, CLL, T cell lymphomas all may be different.
Perfect. Thank you for all of those very informative answers. As you leave the session today, we would appreciate you taking 2 to 3 minutes to fill out a brief survey about your experience during today's event. You can also suggest topics that you'd like to see in the future, and we're always looking to cover what matters most to you, so we'd really appreciate your feedback. I also wanted to quickly highlight a few of our upcoming events. So on September 3rd, we have an event about navigating insurance changes when you're living with blood cancer. On September 10th, we have a podcast coming out about some early stage research exploring the science behind a keto diet and CAR T therapy. And on September 15th, we have a webinar about the future of lymphoma treatment and what's in the research pipeline. We have a lot more exciting events in the works, so stay tuned. The link to sign up for these events and many others will be sent out in the follow-up email. We also have a number of upcoming in-person events. Connect to Cures allows you to connect with other patients, learn from doctors, and discover resources in your area to help you navigate cancer. If you're interested in attending any of these events, the QR code to register is on the screen. Before we wrap up, I just want to say a huge thank you again to Dr. Rhodes for that amazing presentation, and thank you to all of you for being part of our lymphoma community. Your support means so much, and we're so grateful to have you here. I've included my email on this slide, so please don't hesitate to reach out if you have any questions, and I look forward to seeing you at another webinar soon.
Thanks, everyone.